Health, Heart, and Vascular Center in Duluth, Minnesota. She joined Essentia Health in 2017. Prior to that, Dr. Benzinger earned a Bachelor of Arts with honors at Macalester College in St. Paul, Minnesota. She received her medical degree from the University of Minnesota, and subsequently she completed her residency training at University of Washington in Seattle. She went on to complete fellowship training in cardiology at the University of Washington, where she also completed her Master's of Public Health in Health Metrics and Evaluation work. Dr. Benzinger has participated in many clinical trials, including the consortium primary investigator for the Preventable study. She has presided over heart and vascular research programs since her arrival in 2017 and has helped Essentia Health achieve substantial growth in its research efforts and expanding care of patients into cutting-edge medicine. She's an active member of the American Heart Association and speaks at local Go Red for Women events promoting women's cardiovascular disease, as well as sits on a number of national AHA epidemiology committees. She is an adjunct professor at the University of Minnesota. Her interests include preventative cardiology, hypertension, lipid management, coronary artery disease, valvular heart disease, and women's heart disease. She's board certified in advanced echocardiography, and she previously presented this lecture at the Texla Telehealth Resource Center's Telemedicine Echo, where it was very positively received, so much so that we thought we'd invite her back again today so that she could share it with everyone else. If you would all please join me in welcoming Dr. Benzinger.
Thank you so much for the invitation to come and talk to you and your colleagues today, and for that kind introduction. This talk today was based on a paper that I had written with one of my mentors, Neil Stone at Northwestern, at the start of the pandemic, when all of our cardiology clinics were, as I'm sure in Texas as well, were being shut down because of the unknown situation with the pandemic. And we were having a conversation about how do we deliver our cardiovascular care, during these telephone visits or sometimes video visits. And prior to COVID, because of our large rural area, and I'm based in Duluth, Minnesota, and we serve patients all the way to the Upper Peninsula of Michigan, northern part of Wisconsin, northern part of Minnesota, and North Dakota, we were doing some telehealth and had some experience with that. And so this is sort of our guide for a patient-assisted virtual physical exam. And I hope that you learned something today. Happy to take questions, and I have no conflicts of interest. So our goals today, we're just going to get some definitions out of the way, kind of how we define telehealth, describe the Telehealth 10, a patient-assisted exam, and talk about changes in ambulatory visits at Essentia in the last year, and then sort of talk briefly about future directions and things that I think are needed to better improve this in terms of documentation and technology moving forward. So I think the doctor-patient relationship is obviously at the center of all clinic visits. And, this component of having this relationship can transcend age, gender, appearance. And it really, patients have confidence in their doctors if they have the 3 C's. If they're caring, they communicate well, and if they seem competent. Physicians who sit down, listen, explain, talk directly and clearly to patients, be honest about what they know and don't know, be okay saying, I don't know, are physicians who are showing these 3 C's. And unfortunately, in the presence of not being in the room with the patient, sometimes you can have some barriers to be able to perform the 3 C's. Even when you're in person, sometimes there's a sense of lack of caring due to strong pressure on physicians to see more patients, and you don't have as much time as you'd like, or adding on extra patients. But really the secret to caring for patients, as we all know, is caring for the patient. And so this is kind of what, with this in mind, we think about how can we be able to develop that patient-doctor relationship in the virtual visit, as well as be able to perform the 3 C's. So I'm going to define, so telemedicine sort of as the umbrella category, the use of medical information exchange from one site to another via electronic communications to improve a patient's clinical health status. And this sort of can include, teleeducation, as you guys have done with the ECHO program, teleconsultations, telepractice, and then also teleresearch. We define telehealth visits as those where a patient comes to a clinic and sort of as a hub and spoke. I'm in a major kind of more urban center, and the patient is in one of our outreach clinics, and I do the visit over video while the patient is in a clinic where you have access to vital signs and our rooming staff. Virtual visits were a new thing for us last year, where we had more interactive video conference. Patient is at home and the provider is either in clinic, or sometimes some of the providers were doing these from home as well. And then e-visits, our patient is at home and answers kind of questions more electronically. These were done for COVID type visits when you needed to come in and get testing. So we're going to focus mostly, this is for more of a patient-assisted physical exam for both telehealth and virtual visits. It doesn't work quite as well for telephone visits, but that was a large percentage, as I'll show you, of some of our visits during the pandemic, because broadband access isn't as available as you would see some in some urban areas. So I recently looked this up. This is data. We had 162,000 primary care visits through December. I just looked it up recently. We hit 500,000 visits across our system for telehealth, or for virtual visits in the past year, which is a huge increase. And I'm sure a lot of other health systems experience the same thing. About half were telephone visits. Again, that really speaks to the lack of broadband and even cell phone and mobile phone coverage. I'll drive to some of my outreach sites a couple hours away, and I won't have any cell phone coverage for about a half hour of the drive. 39% were via video, and the platform we used was Zoom, and then 9% weren't recorded. For primary care, the top diagnoses that were done for virtual visits were, the opiate visits for refills, hypertension, well child checks, type 2 diabetes, and anxiety. Whereas in cardiology, we performed over kind of the pandemic 12,000 virtual visits. We still had 32,000 that were in person. A lot of our heart failure patients and other patients who were having active symptoms and needed, for example, electrocardiogram or other things were deemed appropriate to come in to the clinic. And again, a lot of our visits initially were done telephone and then quarter video conference. And we are seeing a lot of patients for coronary artery disease, heart failure, both systolic and diastolic, atrial fibrillation, and hypertension. This is, again, sort of a distribution of our telehealth locations where our patients would come into some of our remote clinics. And then Duluth is here on the tip of Lake Superior. This is Lake Superior with a cargo ship that we see from the hospital. And when you look at kind of the difference between primary care and cardiology, a lot of primary care here in the whitish gray, we're a lot younger. And I think that speaks to the fact that, they're a little bit more tech savvy, a higher percentage of video visits among primary care, where cardiology patients, generally I'm seeing 70s, 80-year-olds, and much lower use of video visits. When we look at our trends in our cardiology visits, the black line is the in-person visits, and then the gray were the video visits, or virtual visits, which included both video and telehealth. And so as most places, March 18th, Minnesota had its lockdown. And so all the clinics closed for a period of time. And there was rapid, increase where we were able to replace almost 100% of all the clinic visits with virtual visits. And then if, patients did need to come in, then these were the more urgent patients who came in. And then over time, this gray line you can see has gone down, but it has not gone down to zero. So they still make up about, 10-15% of all of our clinic visits. We are continuing to do virtual. Some patients really like them, and it's a nice option for people to not have to travel. So I think as you know, telehealth has really expanded, particularly in the last year, and I think continues to have the potential to be a major part of how we deliver medical care, especially across the distance in rural areas. But I think there's still a lot of things that need to be worked up, and more wearable sensors and some remote monitoring capabilities I think would be really helpful to help this expand and kind of be more similar to an in-person visit. Continuous advancements in electronic health records and clinical decision support to help figure out who is more appropriate for a virtual visit versus an in-person visit. And then in terms of documentation and recording sort of the differences and things like patient-assisted physical exams. There are obviously shortages in healthcare workforce, especially in our area, and so we can't be sending, specialists to a lot of these areas. So I think virtual visits is a great way to be able to more efficiently see somebody. I was on call a few months ago and got a call from a local ER. All the hospitals were full. Patient was having chest pain. I was able to do a virtual visit with them, get them in for an outpatient cardiac catheterization procedure the next day. Because they weren't able to get transferred. There were no inpatient beds, but I could arrange the procedure to be done as an outpatient. They seemed stable enough. They came in, he had multi-vessel disease and was able to come in for surgery the following day. And so I think that virtual visit really helped expedite his care and evaluation and saved him from having to get admitted or delay his care. And then I think there's the reimbursement for telehealth visits and things will obviously continue to evolve. And I think the change in reimbursement during the pandemic really was an incentive for our health system to switch to this method. Wisconsin was the first to cut off the telephone visits as being, I think, reimbursed. And so that was a huge barrier then for us to be able to provide virtual visits in that area because there's a lot of our patients don't have broadband in the northern Wisconsin area. And then I think just public expectations around demanding that they want this and wanting real-time access to medical providers and things I think will also drive the expansion of telehealth. So with that, I want to get into the Telehealth 10. So the Telehealth 10 it's a physical exam that a patient can help because you're not in person. And that's always been, I think, people's big concerns about doing virtual visits. And I think it is possible to be able to elicit a lot of the things that you do get from a clinic visit and some of the key components. And obviously this isn't a comprehensive list. This is really tailored towards more of a chronic disease visit, especially as it relates to the patient seeing a cardiologist. It's not appropriate, obviously, probably for pediatrics when you need to get head circumference and other measurements. It's probably not appropriate for an ophthalmologist or dermatologist or things like that. But it works for cardiology and a lot of chronic disease. And it also is a good way to triage, I think, who actually does need to be seen in clinic. And so it's a nice way, there's a lot of patients who just come in once a year to get their medications refilled. We review their labs, ask about symptoms, and then we see them in another year. And I think those patients are great for video visits. They don't necessarily need an exam. The exam is unlikely to change what I'm going to do unless they're having new or worsening symptoms. So this is the figure. We're going to go through these different components. So step one of any visit is the vital signs. I think home visits, video visits, this is one of the biggest downsides is that I found a lot of my patients, even though they're on antihypertensive medications, don't have an automatic blood pressure cuff or any sort of ability to do home monitoring. I think that's changed a little bit over the last year. I think patients have realized that that is something that they need. We've strongly recommended it. I think some health insurance companies have sent blood pressure cuffs. Our clinics have been allowing patients to check them out. Also patients, I think a lot of them have bought the pulse oximeter monitors, which also give you heart rate. These are important data points. And we usually call the patients ahead of time, and our nurse does and has them, record these if they have them, in advance, so you have some data to review, just like if they were coming in to the clinic. Having them weigh themselves on the day of the visit, if they have a scale, that can be very helpful. Again, during COVID, if they had a thermometer, check their temperature to see if they were having any fevers, and then we talked about pulse oximetry monitoring. There's also been a big expansion in wearables. I have a lot of patients now whose children have bought them Apple Watches to monitor their atrial fibrillation, which I think is great. There's some other, a live core and other devices that can detect if you're in atrial fibrillation or not. But they're, I think more and more of these devices get out into the general community, and we'll have better ways to monitor vital signs for these video visits. Step 2 is the skin assessment. I ask the patient to show me if they have any new bruises, rashes, any other concerning findings. A lot of our patients are on anticoagulation, and so, wanting to ask about bruising and bleeding. We also have to evaluate patients after they've had a pacemaker put in or had a procedure, and so we want to look at their incision or their procedural site, make sure there's no hematoma or anything like that. So it's great with a video. You can have them ask them to show you, their arms or legs. If you have another person in the room, you can have them show you their back or other concerning findings. Step 3 is HEENT. One of the biggest barriers we have for the telephone visits was our patients couldn't hear us. And, a lot of patients are hard of hearing, especially those patients in their 70s and 80s. And so just asking, can you hear me? Is this okay? And sometimes just the pitch of my voice is very hard for some people to hear. So I find I have to scream on the phone or on the headset, ask them if they have hearing aids, ask them to put them in. A lot of people I found weren't wearing hearing aids because it was interfering with their masks. And so having them put them in if they have them. One of the things we look for with our high cholesterol clinic, our lipid clinic, are cholesterol deposits around the eyes. And that's another one that's pretty easy to do with a video. Ask them if they've seen any yellow spots around their eyelids. Also, kids can get them in their elbows and knees, and you can get a thickened Achilles tendon. You can also look for corneal arcus, so cholesterol that deposits in the eye. And so just having them pull their eyelids down and look up, you can look for that. These are obviously patients who you already probably have seen their labs and you know that they have a history of high cholesterol, but these are clinical exam findings that you're trying to confirm when you're seeing these new consults. Step 4 is a neck exam. This is really important for patients who have heart failure or you're worried about their volume status or they have a lot of lower extremity swelling. Excuse me. So usually I have a patient lay back at 45 degrees and just turn their head towards the door, and I look at their neck to look for their JVD and look to see if I can see the pulsation in their neck. You can also just have them turn their head side to side, make sure they have good, range of motion. Asking them to swallow, make sure that they don't have any problems with swallowing. Thyroid disease, why it's usually picked up by primary care. Occasionally, we'll get a case of severe hypo or hyperthyroidism, which can lead to arrhythmias and other problems. Note if they have any masses in their neck or pulsations or anything that they've noticed that's abnormal. And like I said, you can have them turn their head and see if you can see while sitting up the pulsation. This is an example of the external jugular vein, which you look over the clavicle and the head of the sternocleidomastoid to find the internal jugular, and you can find the pulsation above the clavicle, kind of midway between at 45 degrees, usually it's in the middle of the neck here. While they're sitting up, as long as it's at or below the clavicle, then that's usually normal. Step 5 is the lungs. Again, this is one of the limitations of the telehealth visit. When we have patients come into the clinic, we do have a digital stethoscope that we use. We've tried a couple different companies. I don't have one that's my particular favorite. My favorite is my own personal Littmann stethoscope, but some of them you can figure out ways to kind of reduce the noise and be able to hear more clearly. But again, this is an area I think where we continue to need improvement in the technology. And obviously patients at home who are doing video visits probably don't have an electronic stethoscope, but you can just ask them to deeply inhale and exhale through an open mouth, listen to see if they're coughing, they're wheezing, how many words can they say in a sentence. Also having them hold their breath and listen again, just to see, how easy or hard it is for them to hold their breath and to breathe clearly. You can watch them breathe, again, watch them talk and see if there's any signs of impaired respiration. Step 6 is the heart. Again, this is a difficult one without a stethoscope to hear murmurs. Often a lot of our patients have already had an echocardiogram by the time they're coming to us. So we're a little bit suspicious on what you would hear. But even though we can't listen for murmurs, and this is one of those things where if you need someone to end up coming in, then that would be this video visit would be a triage for them to come in so that you can do that heart and lung exam. But at a minimum, they can look and feel their pulse, usually at their wrist, have them place 2 fingers over the wrist, have them count out the beats that they feel, see if there's any skips or pauses, see if they note that it's irregular. A lot of the machines nowadays will also note if it's irregular or not. And so this could be a clue to atrial fibrillation or atrial flutter, or just having a lot of PVCs or other ectopy. I often have patients tell me that their blood pressure cuff doesn't work. It keeps erroring, saying it's error, it's not working. They think it's broken. They try switching the batteries, it still doesn't work. And it's because they're in atrial fibrillation and the device they have is unable to get the blood pressure because of the irregular heart rate. So that can be a clue to have them come in and get an electrocardiogram. Step 7 is the abdominal exam. Again, it's hard when you're over the computer to do a comprehensive abdominal exam, but you can have the patient do part of it for you and really have them push on all 4 quadrants, ask if it's soft, if there's any pain anywhere, ask if it's distended, ask if their pant sizes, pants are fitting more tight than usual. If it is tender or distended, ask them to cough or sneeze or push and let go and see if it's more rebound tenderness or if there is more point tenderness. And then again, this can be used as a triage point to have them come in to get further evaluation and possible imaging. One of the things I always find interesting is when you discover scars on people when you're doing an exam. Some people have had surgeries as a child and they kind of forget about them, or somehow it's not brought up or it's not in their medical record. And so I always ask about if you have any scars or you had any prior surgeries and what were they for, and try to assess if that history is important for your diagnosis. Step 8 of the Telehealth 10 is the extremities. This is important in our clinic. Often we like to feel people's hands and feet, feel if they're hotter or colder than usual. If people have heart failure and they have kind of stage D heart failure where they're really advanced, have very low output, often their extremities are quite cool. The other thing you want to assess for is any edema and note if it's pitting edema. And this is a nice one that we also can do when the patient's in a telehealth visit, where the patient's in our remote clinic. Our clinical assistant will take the video and push her thumb into the shin for a few seconds and then show me, and I can see if there's an indent. And I also have patients do that. I tell them to take their thumb, push it into their mid shin, hold it for 2 or 3 seconds and see if they can feel an indentation. You can also look for sock lines, have them pull down their socks. You can have them put their hands around their calves looking for a DVT, and if one calf is possibly more swollen than the other. Again, these are all ways that you can try to help with your diagnosis in your differential, even though the person isn't in the room with you. Again, for patients in the lipid clinic and who have high cholesterol, you can usually we feel the Achilles tendon and see if it feels lumpy or thicker. And it's a good thing to educate patients about, to notice, and again, just to tell them that this is why it's dangerous to have high cholesterol. It can deposit in different areas. The neurological exam, also you can, as you're talking to the patients, you're getting a sense of their facial expressions and things. I have a number of patients who've had prior strokes. I ask them what their symptoms of their prior strokes are. I have them stretch out their arms, elbows straight, spread their fingers, turn their hands up, and close their eyes. And we look for drift, look for tremor. You can have them, do some of the cranial nerve exam. Again, if you have obviously concern that a patient's having an active stroke, you would have them call 911 and be further assessed. But just to say, it's possible to document kind of what their baseline deficiencies are or where their weakness is, even if you're not with them. The other thing that I think is really useful is to seeing how patients walk. So if there are most patients when I do video visits are usually at a table in their kitchen or in their bedroom, and you can just have them leave whether it's the iPad or tablet or their phone, just on the table, and have them ask them to try to stand up from a seated position and walk to the door and back. And I think you can get a lot of information about proximal muscle weakness as well as their gait. Ask them if they use any assistance like a cane or walker, and just how short of breath they are when they come back from walking to the other side of the room and back. We often do this in the clinic when we have our rooming staff bring them in. You can usually tell if, how much they're huffing and puffing. And so this can be sort of a useful exercise for a video visit. So the last part of the Telehealth 10, which I think is actually one of the most important, is the social determinants of health. And especially when we had all of our clinics shut down and patients were, some patients were not able to work and other things, there was a lot of changes in people's abilities to get access to food, have transportation, have a safe place to stay, get physical activity, get adequate sleep. Everyone, I think, stress was quite high. And so we are systematically asking patients in the clinic through questionnaires about any food insecurities, ability to afford their medicines and other supplies, if they have adequate housing, transportation, if they feel safe at home, as well as starting to assess some of the heart healthy lifestyle. And we've piloted this in our pediatric clinic, and it's getting rolled out to more widely in primary care. And then we connect patients who score high or who have answered, that they have any of these issues with our community connection representatives and try to get them hooked up with local food banks and other things. And so I think this is something that we all need to expand on to be able to, these are questions that we don't routinely ask, but are probably more important in terms of management of blood pressure and blood sugars than the medications is that having access to food and being able to, afford your medications. So I think a picture speaks is worth 1,000 words. Observing a patient in their home is I find it's a very unique experience to be able to be invited into somebody's home and to have that interaction, to see their family members. I think it's great to have patients bring somebody to the visits, and that was one thing during COVID that we didn't allow visitors for a long time. And I think it really is a disservice to the patient to not have a second set of ears to be able to listen to what you're saying and the recommendations. So it is great to have that for telehealth visits and virtual visits, to have another family member there and also see what their surroundings are like, and being able to get a full picture of who this person is and what challenges they might have. I had one person tell me that they have the patients open the refrigerator and look and see, and you can get a lot of information about their heart failure and if they're going to be admitted, based on what's in their refrigerator in terms of the high salt foods or not. So I just want to end with some of the limitations that I found in performing a patient-assisted virtual visits. One is we use Epic for our electronic medical record, and this is an example of my notes. And I think it's set up, for a normal in-person visit, but I found that I really could only document, were they alert? Do they have normal appearance? Were their conjunctiva normal? Was their respiratory effort normal? Did they seem to have no focal neurological deficits? Were they oriented to person, place, and time, and mood? And a lot of these other things, it's really difficult to determine how much you want to document on this normal exam because of the limitations. But I think this is an area where we could improve, and it'd be great to have a separate tab that's the patient assisted, patient reported, I suppose, rather than the physician elicited findings. This is an example of me on Zoom with my clinical assistant and a patient with our digital stethoscope. And then we use the echo program. And so you can see it gives you an EKG, and then I can hear if there's any murmurs. So I think this kind of technology has really helped expand the use of telehealth across our system and make it so we can listen to heart and lungs, like I said, and not have to be physically in the room with the patient. So the future direction of telehealth, I think it's here to stay. Definitely, the popularity of it, I think, is much greater among younger patients. A lot of our older patients, I think, really are used to coming in and seeing their doctors in person, and so it may take a few years to really, for this to really become the more predominant form of clinic visits. But I think it's definitely something that's here to stay and will continue to expand. Like I said, elderly individuals with cognitive impairment or low health literacy or just no access to broadband or telephone, I think are going to be left out. And so I think we have to be really cognizant about rules and things that we make that limit access to people who just, can't afford it or just don't have access to it. And then, I think as patients were forced to use it and they become more comfortable with the technology, the Zoom technology, there was a lot of patients who wanted to use FaceTime, but because of security issues and things, we were not able to do that. I think these are things that we can kind of work through in the future. Interpreters, we don't do a lot with we don't have a lot of non-English speaking patients that I see, and so I didn't have to do any virtual exams with interpreters, but I can see where that would make it maybe easier to access interpreters by doing things virtually, or if you have in-person interpreters, maybe it's easier to do an in-person exam, but just the options I think are there. And then just making sure that, whatever type of visit we're doing, that we're maintaining that physician-patient relationship and meeting their psychosocial needs and demonstrating that caring and communicating in competence like we need to ensure that patient-physician relationship and maintaining that trust, whether it's in person or virtual. I know that's been challenging during these times when we couldn't see and be together in person. And I've gotten feedback from patients now that I initially saw over video and then saw now, and I think they say that they felt like they had our trust and they that we were listening and that we were able to. They were really appreciative that we were able to continue their care in that way. So again, there's some limitations to in-person visits versus the telehealth, but I think the Telehealth 10 is a nice framework for being able to try to overcome some of these limitations. Personally, one of the limitations I found is that our rooming staff has a nice checklist and they do a lot of the medication reconciliation. They go through the allergies, they go through the vital signs. We didn't have anyone checking in our virtual visits. And so that type of stuff was left up to the physicians. And so when you look at quality metrics across the health system and trying to do research and things, a lot of this stuff was not being done or, for example, vital signs being entered. So we have a lot of missing blood pressures on our hypertensive patients and things like that. There's also no printing of an after visit summary, for example, at the end of a visit. Nowadays, though, because of the move to virtual visits, have delivered the after visit summary electronically via the patient portal. And in Epic, the patient portal is called MyChart. And so actually a lot of our patients in clinic are opting to have their after visit summary just sent to them via MyChart. So it comes to them basically in an email rather than getting it printed out. So I think, some of this technology that we use for telehealth is now getting translated back into the clinic, which is great. And then we've had to come up with different clinical protocols to figure out who is most appropriate for these in-person visits versus telehealth visits versus the virtual visits, and we have all sorts of documentation to go with Medicare rules and things about length and why and all of that has been developed. And I think it would be great if it was a little bit more seamless, and that patients could be able to switch from one to the other, and that our standard templates would be more accommodating to these different visits. But it can get really frustrating when you have half clinic patients and virtual visits thrown in there, and you're running behind in clinic, and these people are waiting on Zoom at home for you, and there's no one to tell them that you're running late, like you were if you were in clinic. So again, just some limitations, some things to think about. Special populations also probably need more attention. I know our pediatric group really strongly tried to encourage patients to still come in because a lot of the kids need vaccinations during their well child visits. And so if you obviously do virtual visits, you're not going to be delivering vaccines, and a lot of kids were really behind on their vaccine schedule this year. So these are just things, unintended consequences of trying to promote virtual visits that I think we'll have to learn from and try to improve for the future. So remember the 3 C's: caring, compassion, competence. They're keys to the patient-physician relationship. It is possible to perform a limited but potentially very useful patient-assisted physical exam, and this is just a starting point. There's a lot more things that you could ask the patient to do as it relates to your specialty. And then the other thing is just making sure that they understand what you recommended or you're asking, and so using that closed loop communication and having them repeat back to you what the plan is, I think is also very useful before ending a virtual visit. So any questions?
Thank you, Dr. Benzinger. That's extremely interesting, and it sounds like there's a lot still to be developed around it. And so I'm happy to hear that we're moving forward and we're learning a lot. As we were listening, I did start to think about, do you find that patients are actually more engaged in a patient-assisted physical exam since they take part in it and they're taking an active role in their care, rather than simply being observed and then having measurements and other things taken?
Yeah, I think so. I think partly because we do a better job explaining why we're going to ask them to do these maneuvers or different things. You're trying to have them participate and understand, why it is that you're asking them to do that. Where in the clinic, I find I just have them jump up on the exam table and you just sort of do your movements, and I think there's less, I personally probably don't communicate why I'm doing certain things, why I'm listening, what I'm listening for, like I do in a video visit.
Dr. Phillips asks, how do you feel about data from smartwatches and other commercially available health metric devices?
Well, I think there's going to be a flood of wearable device data coming to us. And so trying to figure out how to filter that most appropriately and have certain criteria for when it triggers attention of a nurse or a tech or somebody to look at that data, rather than it just all flooding physician offices, is going to be really important. But I do find that I have, for example, patients with atrial fibrillation who have it. They don't send it to me every single time that the watch says they're in atrial fibrillation, but it's a nice reminder for them to keep an eye on their heart rate, to stay on their anticoagulation so they don't have a stroke, and these other things. And so I hope that people aren't sending all of the wearable device information to us, but it is additional data points that when they do come for their check-in or their visit, that I think is helpful and can prevent them from needing to have other tests. We frequently do Holter monitors for 48 hours and don't pick up anything. But if someone has a watch that shows they were in AFib last week, they can pull it up on their phone. I can look at it and, based on the Apple Heart Study, know that algorithm's very accurate and has been FDA approved. And, I think based on that, I would say, but depending on their CHA2DS2-VASc score, I'd put them on anticoagulation without repeating a Holter monitor, for example.
Interesting. Dr. Santos?
Yes, thank you very much, Dr. Benzinger, again for guesting in our webinar. And I shared your landmark paper in our chat box. I put a link in there, by the way. And thank you again for your presentation. My question is, can you share with us, what percentage of your practice is currently virtual in seeing your patients? And the other thing, though, is what will you say to our, clinical colleagues who are still resistant? I'm pretty sure there's still some of those in your area as well are resistant on using the virtual platform, and how do you encourage them to adapt this?
So we were all forced to do it as of March of last year. And like I said, in cardiology, we had already started doing the telehealth where patients were in the clinic and we were doing this over video. And so it was the same technology, but then all of a sudden, instead of the patients being in our remote or outreach clinics, they were at home. And all of the clinics just got converted. So anyone who didn't want to do it didn't have a choice. So that was helpful. We did have some hiccups in terms of, patients connecting to the wrong Zoom link or not being in the same room. And those things got worked out by our IT pretty quickly. And so it's pretty seamless, I would say. You click Zoom and they're there, and often they're there waiting, and it's actually, I find personally, I like the video visits. I can type while they're talking and while we're having this visit. And so I get all my documentation done by the time we're done with our conversation, and I have all my orders in. Where when the patient is in the clinic, I find the computer setup is often really cumbersome to be typing, and I'm facing away from the patient. And so I do a lot of my documentation outside of the room afterwards, and that sometimes you get behind, or you have to save your documentation for at home. So I guess for those who are resistant, I mean, it depends on if you're a typer or dictator or how you do your notes. But I would say right now we're doing about 10% of our visits are virtual visits, and basically we'll have one day a month where it's supposed to be all video visits, because it is really hard to have a, like I said, go back and forth, have a clinic in-person day with some video visits mixed in. I will add on clinic virtual visits on for example, when I read echocardiograms and I'm not in a clinic day, I can add on those types of visits. But it's not, so it's not a huge percentage of our current volume, but like I said, it still remains, and it allows people to be seen sooner. So one of the pitches that I make to patients is, I can see you via video visit tomorrow or Thursday, or you have to wait a month to see me when I come to, whatever clinic you're at. And so some people are more than happy to take that option because they can be seen more quickly.
Dr. Phillips asked, do you think robotics are coming to cardiology for some procedures? And if so, what is the first candidate procedure?
I know for cardiothoracic surgery, for example, they're doing a more minimally invasive mitral valve, repairs now. And I think that those are starting to use robotics to do minimally invasive mitral valve repairs. There's, the devices to deploy MitraClips and transcatheter aortic valves, the TAVRs, I think are starting to get, there's some centers that are trying to develop the robotic technology, really just to save the operators from the radiation exposure. So the operators would just be behind a leaded window in the room, scrubbed in, but just, maneuvering the robot, which would, instead of be their, hands at the bedside with these catheters and things. So I think that there's a lot of potential, but it's really, I don't see it replacing a lot of providers. I think you still are going to need a provider to operate the robots and be able to jump in if there's any problems.
So you had mentioned in your presentation the need to address diverse patient populations. I think especially important is to remember underserved patient populations. Has your organization paired with any third parties or set up anything to allow those who might have limited connectivity to go into a designated point where they can then take part in these services, such as libraries, schools, churches?
That's a great idea. And I think what I had heard from some of my patients was that they would just go sit in the library parking lot. The libraries, a lot of them were closed, but the internet was still on. And I had a patient in their car doing the virtual visit from their local library. Um, you know, this also happened with schools. A lot of our schools went to remote learning for the last year, and a lot of kids in some of these areas didn't have access to broadband. And I think this is a national crisis in rural areas, that they need better expansion of broadband or satellite internet to be able to help reduce these disparities in rural and urban areas, as well as underserved urban areas, and just make it more affordable and accessible, because otherwise you're going to really leave, there's going to be a big gap. And you're going to leave a lot of people out who don't have access.
Absolutely. We'll go ahead and open up questions to the broader audience. Please feel free to either type it into chat or unmute and go ahead and ask away. So I do have just one last question. Could you describe sort of the breadth of services that are currently using this assessment and what your thoughts are for expanding it to other services?
So in terms of the patient-assisted physical exam, I think this is, something that all providers who are providing virtual visits can do. We find, so initially primary care were the biggest bulk of the virtual visits, but then since a lot of the primary care visits have gone back to being in person, and a lot of primary care providers are more closely located to patients, I find that I think the telehealth and video visits are really going to be critical for specialty care and delivering specialty care over a distance, and providing that access where you just don't have enough providers. And so whether it's GI or, we do telestroke and teleneurology visits, basically telecardiology. And then now for example, our critical care has a big room of monitors in our main hospital now, and they're remotely watching all the ICUs of about a dozen local hospitals, and so providing that so they're open ICUs, they have hospitalists at these hospitals, but now they have critical care kind of backup to help. And so I think that those different types of telehealth that we talked about, telemonitoring, teleeducation, I think there's a huge umbrella of services that can be provided virtually.
It was interesting that you mentioned pediatrics and a bit of reluctance for folks to engage in virtual care for pediatric services. In Texla's experience, we've been working with the FQHCs and rural health clinics throughout the state, and we found that many parents were reluctant to have their children seen virtually because of a perceived difference in the care, and they wanted to make sure that their child was being seen at the highest possible standard. Do you think that maybe it's just not appropriate for all pediatric services, some but not all?
So I'm an adult trained internal medicine doc, but I do some work with pediatric hypertension and have worked closely with our pediatric cardiologists on some lipid and other projects. I think, again, the specialty care, I think, would really be helpful to improve access. We have very limited pediatric specialists in a lot of our rural areas. Even in the urban area, can be you have to drive down to the Twin Cities to see like a pediatric nephrologist, example, for like hypertension. In terms of it being inferior, I don't think that the visit itself, I mean, I personally believe I provide the same level of care over a video visit versus in person. I review all the primary imaging, I review all the labs, I review all the primary care notes. I give them I use all the training that I have. And so I think the pediatrician, I'm sure, is doing the same thing. I think the limitation is in, for example, I can't get an EKG when the person's at home. And if I need an EKG to make a diagnosis to come up with that plan, you're not gonna be able to get that. Same within pediatrics. If you need to know your kid's growth percentiles and if they're falling off, or if you are due for immunizations, you just can't get that from a virtual visit. So it just depends, I think, but again, better transparency, better algorithms to figure out who's, could this year, could you do a video visit, next year come in for your in-person, vice versa, that type of thing. There's probably a lot of room to improve that.
Thank you. And Dr. Santos asks, do you do in-hospital cardiology telemedicine consultations?
Yeah, so we set that up for the COVID patients. We had a lot of COVID patients for a while this fall. And so instead of having us have to go into the room and other specialists and the hospitalist, we had purchased a number of iPads and then we would leave them in the patients' rooms. Of course, some of them who are cognitively impaired or had other issues, obviously patients in the ICU intubated aren't going to be using your iPad. But for a lot of patients who are just on high flow nasal cannula, sitting on the floor for weeks, rather than continually exposing all the staff to the patients, we were doing, I would just basically sit at the nurse's station and talk to them. I could actually see them through the glass, but it was a way to kind of try to limit our exposures during COVID. And I think that kind of technology will continue, especially now, if we can expand that to some of our smaller critical access hospitals where you could do telecardiology now that we figured out how to set it up, how to make the appointment, how to get the person to sign on. I think that is definitely room for expansion there.
I think Dr. Benzinger, that's a great idea. What's your experience about the reimbursement with the consultation? Because sometimes some of them don't do it because they're kind of worried about reimbursement.
I am part of a large health system, and I fortunately don't have to get involved too much in terms of reimbursement and worrying about different insurance companies. That's usually taken care of on the front end, and so I can't speak to reimbursement for these types of visits. But it's probably an area that we obviously need that needs improvement. I think there was a lot of rules that were, I think President Trump had expanded the reimbursement for a period of time, and then so that really facilitated the growth of this. But then as those rules, like I said, in Wisconsin, for example, got peeled back really quickly, it really impaired our ability to do virtual visits. And also, they also took away you didn't have to be credentialed, for example, in Wisconsin in order to provide virtual visits, and they took that away as part of when the emergency order got retracted. And so it was all of a sudden we would have providers who just, who didn't have a Wisconsin license, who during the pandemic could provide that telehealth, but then all of a sudden, as of like October 1st, no longer could. And so we're scrambling to try to reschedule those patients with different providers who were credentialed in other states and stuff like that. So there's a lot of these insurance and logistical challenges moving forward.
Well, thank you very much, Dr. Benzinger. If there are no more questions, then we will go ahead and conclude. And we do sincerely thank you for your time today. And we'll be happy to have you back to continue to talk about your work on telehealth assessments and cardiology.
Great, thanks. Have a great rest of your day.
Thank you.